Well, thank you very much for joining this AAST webinar brought to you by the Associate Membership Council. My name is Joshua Dilday. I'm the chair of the Education Committee for the Associate Member Council, and I'm joined by our Vice Chair, Alex Schwed, as well as a panel of some wonderful, wonderful experts in the field in emergency general surgery and trauma and critical care, but more importantly, in the realm of biliary disease and some challenges and complications and controversies that we're going to discuss today. So they'll be introduced soon. Dr. Schwed will introduce them, but before them, I just want to explain why we talked about this topic today. So biliary disease can affect so many of our patients, and honestly is a complication or a controversial factor that we see so many times, regardless of our area of training. Every time we think we have a run-of-the-mill biliary patient, whether that be gallstone pancreatitis or choledocholithiasis, sometimes it doesn't go nearly as simple as possible. So today's topic for our virtual grand rounds, and we're very pleased to bring this today, is gallstones and chole tubes and pancreatitis, oh my, dealing with challenging biliary cases. So with that, Dr. Schwed is going to introduce our panelists and we will get going.
Thanks, Josh. I want to echo what you said, that we've really assembled a wonderful panel of experts today who are going to share their expertise and insight and a little bit of opinion and controversy. Our agenda for the day, we're going to talk briefly introductions, and then talk about optimal operative timing for gallstone pancreatitis, talk about the role or lack of role of percutaneous cholecystostomy tubes, talking about an operative first strategy for choledocholithiasis, and then getting some tips and tricks from one of our senior surgical colleagues. Dr. Jessica Keeley is one of my partners. She's one of my personal gallbladder mentors, helps talk me off a ledge every time I have a tough case. She's an assistant health sciences professor at the David Geffen School of Medicine and an attending trauma surgeon here at Herbert UCLA. Mira Ghneim is an assistant professor in the program in trauma at the University of Maryland Shock Trauma Center, and she's also the associate program director for the Surgical Critical Care and Acute Care Fellowships at the RM's Cali Shock Trauma Center. Dr. Patrick Murphy is an assistant professor of surgery at the Medical College of Wisconsin, where he works with Dr. Dilday. And finally, Dr. Matthew Martin is a professor of surgery at the USC Keck School of Medicine and is a self-professed gallbladder nihilist. So I'll be curious to hear what he has to say about tips and tricks for complicated biliary disease. With no further ado, we'd like to get started. But before then, we'd like to have our folks who are on the call please note that the AAST no longer offers CME for live grand rounds. Should CME be available for the archived version of today's grand round talks, those who watch today's grand rounds can receive an email once the archive version is available on the website, and that will prompt you to log in and claim your CME if it is in fact available. So with that, I want to turn it over to Dr. Jessica Keeley, who's going to talk about ideal operative timing for gallstone pancreatitis.
Hey guys, let me share my screen. I think I can do this. Is that okay?
Good job.
All right. So gallstone pancreatitis is not a typo. The real subtitle is when, and how do I decide? This is going to be a little bit evidence heavy because there is much evidence that we seem to be ignoring. Okay, I'll do this way. I have no disclosures, unfortunately. We're quickly going to talk a little bit about terminology because papers discussing gallstone pancreatitis and when to operate all kind of flip things upside down depending on how they're feeling that day. So we all know gallstone pancreatitis, early cholecystectomy. In our context for today is going to mean index cholecystectomy, meaning you did it during the index hospitalization. So you come in, you have pancreatitis, I take your gallbladder out, life is good. That's an early cholecystectomy. Caveat, there are papers that discuss early within the index hospitalization, meaning did you get your gallbladder out in the first 2 days, or did you get it out a week later, but you sat in the hospital for that week? We're going to say early and index are the same. Delayed cholecystectomy, same thing. Many papers, delayed cholecystectomy means you went home, you came back. Later on, say in the late 2010s until now, delayed cholecystectomy means you got your gallbladder out more than 48 hours after admission. This is confusing. So we're going to say delayed is delayed, meaning later in your hospitalization, and we'll use interval cholecystectomy to mean done during a subsequent admission. So for some reason, you had your gallstone pancreatitis diagnosed, you did great, you went home for an unknown amount of time, had gallstone pancreatitis an unknown additional amount of times, and then came back and got your gallbladder out. And non-operative management is self-explanatory. All right, why do we care? Gallstone pancreatitis accounts for more than 50% of acute pancreatitis. Without timely treatment, patients have an increased risk for disease progression. We all know pancreatitis is bad. Moderate and severe pancreatitis still carries significant morbidity and mortality, no matter how good we are at resuscitating people and getting them through that. And mild pancreatitis is really no fun for anyone. We've all seen folks come in excruciating pain. With this, even though recommendations suggest early cholecystectomy or cholecystectomy during initial hospitalization, we're really, really, really bad, we the greater we of surgery, at adhering to these guidelines and recommendations for management. So this is just for completeness. So one day you hopefully can claim CME for this. How do we diagnose gallstone panc? We all know abdominal pain, you have some elevated labs, you have imaging with gallstones or sludge. Had to include some awkward Yeti. But now you have this. Someone comes in, they've got some pain, they don't have any evidence of severe or what you think of moderate pancreatitis. Now what? Should we press on their belly every 12 hours until they have no pain? Should we check their lipase and amylase daily? Should they go for an MRCP because obviously there's some gallstone probably sitting in their common duct? Should they just go straight to ERCP? Or should we go straight to the OR, no more questions asked? And we're still trying to answer these questions, apparently. So how do you decide? For today's talk, because it's limited in time, we're really going to talk, and because we're surgeons, we're going to focus on when to go to the OR. The workup of possible cholangitis and choledocholithiasis with gallstone pancreatitis is really a more complex topic for another day. But we will talk about severity of pancreatitis, run through some scoring systems. And as I said, these are possible diagnoses, but for the sake of today, we're not going to run through the very complex algorithm of imaging and possible preoperative interventions. So we're going to focus on isolated gallstone pancreatitis. Grading systems. I stole these from other places. Obviously, I did not recreate them for you today. Ranson criteria listed here, not complete until you're at 48 hours. CT severity index, have to have a CT scan, which not all of our patients do. Revised Atlanta criteria, again, a little bit better, more clinical, but if we're going to start talking about local complications like fluid collections and pseudocysts, again, requires imaging. And then BISAP score here, you can see is really clinically based. And then the addition of pleural effusion can get a little dicey depending on where you practice, if everyone gets a chest x-ray or has other imaging. Why am I boring you with these scoring systems and going through things that you maybe don't want to think about? Again, why do we care? These gallbladders working so hard and making his little stones. We care because the severity of pancreatitis really is going to lead us to early operative intervention. So going back to our slides of severity, if you have mild pancreatitis, you should be operating on that patient during their index hospitalization. If you're unable to define what mild pancreatitis is, then it makes it a little harder to make that decision. Okay. So we're going to talk about timing, and then we're going to talk about outcomes. Why do I care? I care because patient outcomes matter. All right, so mild pancreatitis. You've decided which scoring system you like the best. Turns out people have compared these. Really, no one system is better than the others. The easier bedside systems are going to be Revised Atlanta and BISAP. But again, when compared, looking at morbidity and mortality, they have relatively equal predictors of outcomes and severity of disease. So it's kind of dealer's choice. So you've diagnosed someone with mild gallstone pancreatitis. Now what? Should you do a same admission chole, or should you send them home and say, come back in 2 weeks, 4 weeks, 6 weeks, because there's a strike and suddenly there's no nursing? So we actually have randomized control trials looking at this. The Poncho trial, and all the references are at the bottom of the slides for future reference, was a multi-center randomized control trial. It looked at same admission cholecystectomy versus interval, and they saw a reduced risk of mortality and readmission from gallstone-related complications, and that included recurrent pancreatitis. That's seen in multiple studies. Yet, despite this data, we still send more than half of our patients home without undergoing a cholecystectomy. A little bit worrisome. All right. How do we do? We've looked at it over and over. 2010, 2010, 22. If you look at cholecystectomy during index hospitalization for mild gallstone pancreatitis over the years and compare 2010 to 2018, we're actually doing worse. This is a national readmission database study. Less than 50% in both groups had their gallbladder out during their first admission. As of 2018, only 37% of patients were having their surgery. Back in 2010, we almost hit 50%, so not great for us overall. There's a higher 30-day readmission for patients who underwent ERCP. So the caveat of, oh, but I sent them to GI, they had a sphincterotomy, doesn't matter, doesn't actually change their readmission risk. All right, we look at the VA, 30% index cholecystectomy, very poor. Only 20% came back for an interval cholecystectomy, and 50% just never had their gallbladder out if they got sent home after having gallstone pancreatitis. And of those, a very small percent, that's a 5.9% of the 50%. So really 2.5% of people had just an ERCP. So again, not doing great. And you may say, but that's only a couple studies. Why do we care? But the evidence, there's so much. So if you look at these, they're small. I apologize if you're on your phone, this is just chicken scratch to you. But all of these studies look at early cholecystectomy and compare it to late or interval cholecystectomy. Some are small and randomized, many are meta-analyses, and all show specific benefits to early cholecystectomy. So if you don't do it, you have an increased risk of recurrent biliary events in the interval group. If you look at a meta-analysis of randomized trials and retrospective studies, continues to show that early chole is safe. If you have the interval group, they have a longer length of stay, which makes sense. It requires at least 2 presentations. And gallstone-related complications are higher in the folks who keep their gallbladder. They still have gallstones. And those risks are not just recurrent gallstone pancreatitis, but acute chole, obstructive jaundice, and even acute cholangitis, which we all know is bad. Again, meta-analysis, early chole doesn't increase the risk of intraoperative or postoperative complications, reduces readmission rates, gallbladder gone, can no longer drop stones. Again, systematic review, 8 cohort studies in a randomized trial. The interval chole group had a higher rate of readmission for recurrent biliary events, especially gallstone pancreatitis in their study. And then one more national readmission database study saying mild gallstone pancreatitis, again, only 30% underwent elective chole. So now we've moved up a few years from 2018, we're at 2022, and we're doing even worse, right? We went from nearly 50% to 37% to 30% for early chole. Non-operative management, again, increased the risk of recurrence, unplanned readmission, and increased 180-day mortality, and increased mortality during readmission in that 180 days. And of course, increased length of stay because you've got at least 2 hospitalizations. So you've decided you believe the evidence. Early cholecystectomy is good for mild gallstone pancreatitis. It's fun, right? Because we're surgeons, we like to operate. So how long do you wait? You've got someone in the hospital, they have a touch of the pancreatitis, but they have no local or systemic complications, so no end organ dysfunction. If you have imaging, there's no clear fluid collection or other complication. So we've got older evidence from 1988 in open cholecystectomy, and they actually looked at patients who had mild gallstone pancreatitis who were operated on in less than 2 days. They had similar outcomes, so those operated on over 2 days from admission. In 2010, we've got randomized trial in a single institution, again, looking at early chole. This is within 48 hours versus control, which was after resolution of pain and normalized labs. Those folks in the early group had a shorter length of stays. There was no difference in conversion rate, and there was no difference in perioperative complications. If we look a little broader, look at NISQIP data from a few years ago. Early cholecystectomy, again, within 48 hours compared to later, greater than 2 days. Reduced length of stay, and in this study, operative time, although I'm not sure what to make of that, and was not associated with any increased morbidity or risk of reoperation. And then looking at 2 institutions go back a few years to 2012, we looked early versus greater than 2 days. Again, reduced length of stay, no difference in complications, no difference in conversion, and no difference in readmission. So no delayed complications in that early group. There's an additional study at the bottom that wasn't summarized here. So, I think there's really good data to suggest that in mild gallstone pancreatitis, operating on within 24 to 48 hours benefits them in several ways, and you don't have to see them for more than 2 days. But for them, they get a shorter length of stay, no increased risk of morbidity, and no increased risk of associated complications from leaving their gallbladder in, to do it at a more convenient time within the system. So, hey, I've got operative time in 2 weeks or next month. you've put that person at real risk of having recurrent pancreatitis, choledocholitis, or cholangitis. And we know just because you had mild gallstone pancreatitis the first time does not mean you're not going to have a severe episode the next time. So getting their gallbladder out is, based on all the evidence we have, really protective of those additional complications. All right, so how fast? Again, we're going to talk a little bit. So now we're like, okay, cool. We should do it within 2 days. They have mild pancreatitis. Great. So how fast? Can we do it even faster? So this is a trial from 2019, Gallstone Panc trial. And they looked at lap chole with IOC within 24 hours of presentation, rather than 48, versus after clinical resolution of pain and labs. And again, they showed a decreased length of stay. They showed fewer ERCPs and a faster time to surgery. They didn't show any increase in morbidity, although it's a relatively small trial. So again, good. Just take it out. I like taking out gallbladders, so I might be a little biased, but I think I hope I've shown that evidence really supports early cholecystectomy. So, final thoughts: mild gallstone pancreatitis, your scoring system of choice. Again, none is better than the other. I prefer either BISAP or Revised Atlanta for ease of use, and they've been used in the more recent studies looking at severity of gallstone pancreatitis. But mild, get to the OR. And you may argue and say, well, you can't complete all the scoring systems within 24. You're really at 48 hours already. I would say most folks who don't have multiple points on, even if you're going to use ranch, and even if you want to go all the way to use Apache too, if you've got minimal evidence of moderate and severe disease in terms of scoring at 24 hours, you're probably safe to proceed. If people are not getting clinically worse, they're not distended, tachycardic, have other signs of end organ dysfunction, you should be safe to proceed. So get to the OR. If it looks like this, don't dive in. This is a complicated pseudocyst. Someone's clearly had episodes before. They've got a thickened gallbladder with some fluid around it. This is probably not the person who 1 day from now you're going to want to try to do a lap chole on. Please don't. So moderate and severe disease, there's been a recent study in JAMA Surgery, August of this year. It was actually a post hoc look at moderate and severe disease and timing to OR, and they saw that those folks who went to the OR within 2 weeks did worse. But again, these folks had lots of necrosectomies in association with their cholecystectomy. So really not clear that taking them for their gallbladder alone was why they had more complications, but because they had moderate and severe pancreatitis and the associated complications. So you should certainly wait. It's an unclear timeline, somewhere between 2 and 6 weeks. But again, this should be individualized, the level of disease, the local complications, i.e., do you have a large pseudocyst that's going to need intervention at the same time? Do you have choledocho or a history of choledocho or cholangitis? They have a stent in place. Did their colon die from their severe pancreatitis? Did they have abdominal compartment syndrome? All of these things. This is a different disease process than what we're talking about in mild gallstone pancreatitis. IOC routine versus selective. That's a whole can of worms. I perform IOCs for everyone with gallstone pancreatitis. That is an institutional practice here. There are arguments for both sides. And then what do you do if that's positive? And I think we're going to hear a little bit about owning the common bile duct later. Versus ceding to our GI colleagues. So I can't help myself with the gallbladder comments. I've got the stuffed gallbladder behind me. But I think what I want to drive home is gallstone pancreatitis. You've decided it is mild disease. Please take that patient's gallbladder out. If you want to shoot an IOC, do it, especially if it's indicated. Any of the standard indications, they have a mild elevation of bilirubin, less than 4, transaminitis, the duct is big, go ahead. But please take out the gallbladder, save that patient from the possibility of recurrent pancreatitis or other biliary complications. And thank you from Harvard.
Dr. Keeley, that was great. Thank you so much. Those numbers nationally and in the community were much lower than I thought. So I'm interested to hear some questions at the end about why you think that is. So moving on towards Dr. Ghneim, we'd love to hear about percutaneous cholecystostomy, and I really want to hear the controversy of this. So I'm very excited. Without further ado, we'd love to have you go ahead.
Thanks. Can you guys actually see my screen?
We can.
Excellent. All right. Thank you for inviting me to present. I don't have any financial disclosures. My only disclosure is that I personally despise cholecystostomy tubes. I don't like to put them in patients or do the gallbladders after they've been put in. So just as a quick review, as you all already know, acute cholecystitis is either a function of gallstones or biliary stasis, both of which would occlude a gallbladder, lead to gallbladder wall ischemia thickening and edema and thickening, and in some cases ischemia and necrosis. But since about 95% of the cholecystitis that we see is due to gallstones, that's going to be the focus of what I'm going to talk about for the next 8 or 9 minutes. One of the more popular acute cholecystitis classification systems that we hear about frequently are the Tokyo guidelines, and they do classify acute cholecystitis into mild to severe. And it's based on what a gallbladder looks like on imaging, but also how sick the patient is from the cholecystitis itself, and does not necessarily take into account any baseline characteristics of the patient. Now, I think in order to understand why we should not be putting cholecystostomy tubes in a lot of the patients, but rather a select group of patients, it's important to understand how we historically changed our management of cholecystitis. So before the 80s and 90s, an open cholecystectomy was the standard of care. And then in the 80s and 90s, lap choles were performed in the US and in Europe. And then a huge body of literature followed that work, most of which were really well-designed studies and some RCTs that showed that a lap chole is actually associated with less mortality, less infectious complications, lower hospital length of stay, and equivocal complications that we're worried about, specifically biliary complications. And so there was a shift. We started to do more laparoscopic cholecystectomies. The equipment that we used became more advanced, and our outcomes got better with time. But like everything in life, there have to be some naysayers. So as we started doing more lap choles, studies started coming about that looked at outcomes, focusing specifically on mortality, as well as focusing on the rate of conversion to open. These are very small studies, single institutions, very, very heterogeneous patient populations that suggested that maybe a cholecystostomy tube will be safer than doing a lap chole for some cases of acute cholecystitis, although they didn't really define what that patient population was. And then in 2013, the Tokyo guidelines basically suggested that for grade 2 and grade 3 cholecystitis, patients who failed antibiotic therapy should get a surgical or percutaneous drainage, and then suggested an interval cholecystectomy later. Now, 2 important things about this is that if you look at the guidelines, they don't actually cite a single study to support this suggestion, and they don't really talk about what is the timing of the interval cholecystectomy. But I think there is a shift in how we took care of patients after some of this evidence in the 2013 guidelines, and we started placing more cholecystostomy tubes in certain patients, although the indications were not always clear. And then we didn't really have clear indications as to who and when would actually get their cholecystectomy after the tubes were placed. And in my mind, I think 2 kinds of populations existed: the high-risk gallbladder itself, which was defined in terms of symptoms. So how long has the patient had their symptoms? How inflamed does the gallbladder look on ultrasound? And maybe if we drain it, then it will cool off, and then maybe we will reduce complications like converting to open, bile tree injury, blood loss, and operative times. And the other group are the actual high-risk patient. So the critically ill patient, they're not suitable for surgery patients, and then pregnant patients, cirrhotics, and older adults. So for a while, I think every gallbladder, or a larger number of gallbladders, were being attacked by cholecystostomy tubes, and there's just more liberal use. But in about the 7 years or so after the Tokyo guidelines came out in 2013, the World Society of Emergency Surgery published guidelines in 2016 that actually included evidence-based medicine. So studies that showed that a lap chole is actually superior to percutaneous drainage, or at least length of stay and biliary complications are less. The Tokyo guidelines themselves expanded on what they had suggested in 2013, and they added a caveat for the grade 2 and grade 3 gallbladders, saying that based on how sick a patient is. So they included Apache score and Charleston comorbidity index, but it was also contingent on the presence of a skilled surgeon, whatever that means, and then introduced a bailout option that was in the form of a lap subtotal, or even just converting to open. And then in 2020, the World Society of Emergency Surgery updated their guidelines based on some more evidence that came about between 2013 and 2020 about how we should be managing patients. And in the next couple of slides, I'll tell you why you shouldn't put a cholecystostomy tube in someone, simply because there's really no evidence to support it, with the exception of a very small patient population. So their current guidelines are for lap chole to be performed as the first line of treatment for all acute cholecystitis. And if the question is, what do we do about that high-risk gallbladder, the patient who's maybe had symptoms 10, 11, 12, or 15 days, and maybe because the symptoms have taken forever, then the gallbladder is inflamed and we're going to cause injury to the biliary tree? The answer is there's zero studies that have actually compared lap chole to a perc drainage in patients that have acute cholecystitis simply based on symptom duration or simply based on what a gallbladder looks like. However, a lot of studies have looked at early versus delayed cholecystectomy, which actually compares having a chole versus just being treated with antibiotics based on symptoms. These studies are very well designed, including an RCT and a very large meta-analysis that showed that having a cholecystectomy earlier is better in terms of all the things that we're worried about. So less mortality, there's no difference in bile duct injury, there's no difference in bile leakage. And while some consider converting to open to failure, there's no difference in converting to open. And the patients have a shorter hospital length of stay and have decreased hospital costs. Now, in terms of the actual high-risk patient, I think it's important to distinguish between two populations. The critically ill patient that's ill because of the cholecystitis, and then the critically ill patient because of something else, they have multi-organ system failure, versus the patient who is not a surgical candidate in general, i.e. will not tolerate anesthesia. I think patients who have multi-organ system failure fall into that second category, in which they're not actually going to tolerate anesthesia. For the critically ill patient who's sick from their cholecystitis, the current recommendations are to actually do a laparoscopic cholecystectomy and not actually drain them. There isn't any evidence to support the cholecystostomy tubes. In fact, there's evidence against it. So this is a Dutch study from 2016. It's a systematic review and a meta-analysis of about 337,000 patients. 10,000 of them had cholecystostomy tubes and the rest had choles. And the laparoscopic cholecystectomy group were all critically ill patients from the cholecystitis. Most of them had less mortality and less hospital length of stay, and they required less, of course, interventions for biliary complications. Another study that people talk about is the chocolate study. So it's well designed in that it's a randomized control study, and it compared biliary drainage to lap chole in critically ill patients that were actually primarily sick from their cholecystitis. And they showed that a lap chole was associated with less mortality, less infectious complications, and less biliary complications. But the huge caveat when you read the study or look at the study is that they excluded patients whose Apache scores were higher than 15. They also excluded patients who were pregnant or had decompensated cirrhosis or had symptoms longer than 7 days. So you can take it either way from that standpoint. In terms of the patients who were not suitable surgical candidates or patients who are refusing surgery, the options are basically based on how sick a patient is. If they're not septic, then non-operative management with antibiotics is sufficient enough for acute cholecystitis. If they are septic and the sepsis is from the gallbladder itself, then you could potentially drain them. The recommendation is to drain them with a perc chole tube. For some of the special populations that give us palpitations when we meet them in the emergency room, so the cirrhotic, the older adult, and the pregnant patient, the current recommendations are actually to perform cholecystectomies in Child's A and B cirrhotic patients in older adults, including patients that are advanced age, so 80 plus, as well as patients who are pregnant. There are no studies that have actually compared lap chole to a perc chole tube in cirrhotics. The indication would be similar to the general population in terms of they were like critically ill and can't actually tolerate anesthesia. For older adults, there's one study that was published in Jackson 2017 that looked at grade 3 cholecystitis and the placement of cholecystostomy tubes and outcomes in these patients. And when placing cholecystostomy tubes in this patient population, they had a higher risk of readmissions. They had actually higher 30, 90, and 2-year mortality, and they were less likely to have cholecystectomies and actually had a lot more complications with their cholecystostomy tubes. In terms of pregnant patients, there's literally zero literature. The recommendation at all stages of pregnancy, regardless of symptom duration, is to perform a cholecystectomy to basically avoid complications, reduce complications to both the mother and the fetus. And if the lack of evidence to support putting a per chole tube in most of the patients that we see is not enough, they don't come for free, so they're associated with a lot of complications, malpositioning, dislodgements, replacements, recurrence of biliary symptoms, and about anywhere between a 4% to 50% mortality. It's never the actual solution. The patients still always need an operation. This is temporizing, especially when we place them for gallstones and the biliary tree remains obstructed. There is really no evidence as to when the optimal timing is, and the 6 to 8 weeks that we choose to select is based on really expert opinion and very few well-designed studies that determine the correct timing. And finally, if the idea is that putting a cholecystostomy tube in someone is going to make the operation better the next time you come to do it, the answer is the complete opposite. This study was published in the Journal of Trauma in 2017 and looked at a large number of patients who had a cholecystostomy tube, and the interval cholecystectomy actually took longer to do. There was more blood loss, and it was a higher rate of converting to open. So basically all the things that we try to avoid by placing a cholecystostomy tube, at least if we base it on what a gallbladder looks like on imaging. And so who should we be doing this for? I think for the patient who doesn't want surgery. I think for the patient who either permanently can not tolerate anesthesia, and this is going to be their treatment forever. Their cardiac risk is too high. I think for the critically ill patient, not from cholecystitis, who at the moment in time that you meet them cannot tolerate anesthesia, but ultimately will become, they will leave the hospital and be able to get an operation. Patients who are cancer patients, so this is like lymphoma, leukemia, other kinds of cancers, patients that are actively getting chemotherapy. And then every once in a while when you get the rare gallbladder perforation that needs drainage. For me personally, if it's not any one of these, then I will take out the gallbladder unless there's no operating room in the place where I'm practicing. And so just do it, take it out. We do a good job taking them out. We know the patients do better, they're happier, and you don't have to delay their care. That's all I have. Happy to answer questions at the end.
That was awesome. Thank you. I think as the moderator, I'm supposed to be impartial, but I think you and I share many of the same biases, but it's great to see data that supports that gestalt. And so definitely there's going to be some good discussion at the end. We've already had one Q&A come through, and so please keep them coming. With no further ado, Dr. Patrick Murphy to talk about the common bile duct.
Thanks. I appreciate being here. This is a topic near and dear to my heart, and hopefully I can convince some of you to do more surgery maybe. A few disclosures. I do consult for Boston Scientific occasionally through MTW. I am not a biliary surgeon. I'm definitely not a formally trained MIS surgeon, that's for sure. I do love the robot. And our institutional culture is selective IOC, which in our context means that if anything is red on Epic or the imaging is read as abnormal, they get an IOC. So the bile duct's dilated. So maybe more liberal than some people. So I'm going to talk about the risks and benefits of a direct surgery approach for patients with suspected choroidal lithiasis. Kind of demonstrate some real world effectiveness about why a surgery first approach is good for the patient, good for you, and good for the system. And as I go through this, unless everyone on the call already does this, I want you to think about maybe some local or institutional barriers about why you don't do this after I tell you why you might should and how you might overcome these, and I'm happy to tell you how we overcame ours. Just to set the stage, and I do have a poll here. I have no idea if it's going to work, but we can always just get people to type in. This is what I would consider a very typical patient presenting with biliary disease to the emergency room. Let's call her 67 with right upper quadrant pain. Sounds like acute cholecystitis, worse when eating fatty foods, typical comorbidities, typical exam, typical imaging, and some maybe atypical labs for most gallstone disease, but suggestion that it's not just acute cholecystitis, but maybe choledocholithiasis, but they did not see any common bile duct stones on imaging. I have no idea if this is going to work, but if someone wants to try, they're welcome to. I bet it's not going to work, but if someone tries and it does, and if it doesn't, maybe I'll just ask the other people whose faces I can see what they would do real quick. We'll just do a little mini straw poll.
Got an error message when I texted you.
Okay, then
I would do a
that.
lap Chole with IOC. I don't know
Okay.
how to use the robot.
Biased crowd. Josh?
I'm biased. I would do a lap Chole with IOC.
Mira?
Same here. Luckily, I
God damn. Martin?
I'll say ERCP just to spice it up.
Love it. You don't want to do robot, hey? Jessica?
I'm lap Chole IOC. It's
God, okay. Well,
Can't
this
help
talk is
myself.
basically over. So basically you do have 4 choices, and I will say that sometimes this is like not preventable. Like when I go to the community, I don't even get called to the patient already has their MRCP, ERCP, and lap Chole. But the patient needs their gallbladder out. So the question is, if they're going to get their gallbladder out, why aren't you dealing with what might not even be there just at the time of surgery? It's suspected choledocholithiasis. You have no proof this patient actually has choledocholithiasis. And we'll talk about patients with known choledocholithiasis kind of throughout the talk. But the reality is that they all need their gallbladder out. So why not just do it a one and done procedure? The unfortunate reality is that most patients, kind of similar to that gallstone pancreatitis, don't go direct to surgery, and most patients get some sort of preoperative duct clearance prior to their lap chole, and there's lots of reasons for this. However, the common bile duct is sitting right there. It's readily accessible. You know, you already have the cystic duct isolated ideally. You can safely access the common bile duct either with fluoro or with choledocholoscopy. And this has, you know, numerous benefits. You can avoid multiple procedures, avoid delay to definitive treatment, avoid post-ERCP pancreatitis, make everyone's care cheaper. And if you do have a positive IOC, you can actually clear it. Although one of the themes of this talk is there's nothing wrong with the post-op ERCP if you don't have the equipment or the necessary skill set to do a transcystic common bile duct exploration, although everyone on this call can do a transcystic common bile duct exploration, I assure you. And ultimately, we can make patients better. And kind of the reality is that most IOCs in patients, you know, who have those red values on Epic are actually negative. The stone is either passed, or you the stone flushes when you start shooting your IOC, or they had a bit of sludge in there. That's the reality. And so specifically in those patients with a negative IOC, you've done that patient a great service. You've avoided an unnecessary MRCP, a negative ERCP, an unnecessary anesthetic. You've avoided their risk of post-ERCP pancreatitis. Those patients, you've really helped in a direct-to-surgery approach. The patients with positive IOC, you can still help, but it takes a little more work. So the question is, why not direct-to-surgery? And, you know, some people might say, well, I don't know how to do a transcystic common bile duct exploration. You don't need to know how to do a direct surgery approach. I don't know what to do with positive IOC. We'll talk about what to do with positive IOC. There's lots of established norms. Like I said, you know, when I go to the community, I don't hear about these patients. I can't do direct to surgery unless I change institutional culture. And the reality is that GIs in 2023 are really good at ERCPs. And it can be nice to know, okay, I don't know if the IOC is going to be positive or negative. I have 4 more cases to do. How am I going to fit that into the OR time I have today? I don't want to add on, you know, an extra hour to this case when other patients need care too. So that can be logistically challenging potentially. So there are a few barriers that I think we should address. This is one approach that, you know, SAGE's ACGE says I find it convoluted and variable. I think we should just get rid of it altogether. You're staring at the cystic duct in your lap chole. You can access the common bile duct without issue. So back to this patient, what actually happened to this patient is they went direct to surgery and they had this IOC. They have a positive meniscus sign. So, you give the glucagon, they have to run to pharmacy for that. You start flushing with 200 to 300 cc's of normal saline, the stone doesn't move. So you could just stop, just get a post-op ERCP, nothing wrong with that. The alternative is a transcystic duct exploration. I'm not going to go through all this, but the potato video quality will improve shortly. But basically, you just put a wire down the cystic duct. You're in the common bile duct. You can then put a sheath in to help prevent looping. You can then dilate the cystic duct, this balloon dilation. Here, you're not dilating the common bile duct. Dilate the cystic duct up, and then you put a choledocoscope through. You can also clear the duct with fluoroscopy, and that's very well described, particularly by the Wake Forest people. And so the scope's got a working channel. You can grab the stone out, you pull it out, you recannulate the duct and shoot an IOP through your scope, and you've saved this person, an MRCP, an ERCP, or either pre or post-op, and that's great. I think you've really helped that patient. And so the patients really benefit from the direct-to-surgery approach. It's one and done. Most IOCs are actually negative. Some of this depends on how often you perform them, what the denominator is. And not all positive IOCs need exploration. Glucagon, I guess, works sometimes. Flushing does work sometimes. And there is nothing wrong with the post-op ERCP. You still helped all of those patients with a negative IOC. You still stop that MRCP kind of clinical momentum that patients get before you take their gallbladder out. The evidence would suggest that patients do benefit. Depending on your access to MRCP and ERCP, this can save you 3-4 days in hospital. Where I trained, to get an MRCP was a 2-day wait. And then to get an ERCP was 2 more days after that. And so, the patients get really frustrated when they're sitting around for 4 days. And you avoid, the second general anesthetic. This is a little cost tool you can use, comparing direct to surgery versus the other options. And because lap chole is inherent in all of these pathways, it's really hard to make direct to surgery more expensive. You either have to have the most expensive intraoperative cholangiogram known to man, or have a common bile duct exploration success rate of like 10%, because everyone needs their gallbladder out. So of course, adding additional tests and procedures is going to be more expensive. This is a great paper that just came out recently in April, and really demonstrated that in patients who get ERCP for suspected choledocholithiasis, most of those patients would have been amenable to a direct to surgery or surgery first approach, either just with IOC that's negative, or small stones or sludge that would have been amenable to flushing or choledocoscopy or fluoroscopy. So you can do this at your institution, specifically for these, common problems that I think we all see. This is our pathway, which looks like a straight line. I'm happy to share this if anyone wants it. It basically is a straight line. If you have symptomatic gallstones in our emergency room, they call the acute care surgery team, and we figured it out. So we get the option of what we want that patient to have based on our interaction and review of their, labs and clinical exam and history. And so we decide whether they go to medicine or come to us more likely, they get surgery first or not. And then we have internal guidelines within our division, again, happy to share them, about who gets a direct to surgery, which is pretty much everyone without suspected Moritz syndrome. And I'll give you some examples that we've done recently. So here's just, broad overview of our experience. Suspected and confirmed choledocholithiasis go right to the OR. So we do about 30% IOC rate. Most patients get direct to surgery. Most IOCs are negative. In the last 2 years, we've done about 72 transcystic common bile duct explorations, about the literature rate of success. And you can get kind of fancy. I have some videos here shortly, and I promise I'll wrap up. But this is very doable. And I know because we did it. And again, nothing with post-op ERCP. So here's 3 patient examples. I know I'm running short on time, so I'm just going to put them all up there. But basically, this is like 3 typical examples from my last acute care surgery week. 50-year-old man with gallstone pancreatitis, maybe had choledocholithiasis. A 38-year-old man with maybe choledocholithiasis, definitely gallstone pancreatitis, and a 57-year-old man with probably choledocholithiasis. This guy had a bilirubin of 8. And so you can see, you know, IOC was positive. Great. Flushing didn't work. We cleared him transcystically, got out of hospital very quickly. You can do this robotically as well. And then the last one I want to show, and I'll play all these together. This is the last slide. But basically, that guy with the bilirubin 8 had these 2 enormous stones. We used lithotripsy, broke up all the stones, pushed them all into the duodenum. He went home the next day. And we saved him probably a very challenging ERCP and probably multiple ERCPs, to be quite honest. And so this is, I wouldn't recommend this as your first case potentially of, you know, someone with biliary of 8 taking them direct to surgery. But as you kind of adopt the approach, you can get a little more sophisticated. So how do you do it? You need surgery buy-in, OR buy-in, and specifically where your patients come from buy-in, so the emergency room. It helps to have local champions, and really your patients will benefit through decreased length of stay, less procedures, save some money, and less post-op post-ERCP pancreatitis. That's all I got.
Dr. Murphy, that was great. Obviously, I'm biased because I'm here with you, and interested in the 2 people who taught me how to do this are you and then our next expert, Dr. Martin. But I cannot wait to hear about some of the questions. And I have a ton of questions because I'd love to hear your thoughts on how to implement that in other scenarios. And without further ado, we've got a personal mentor of mine, Dr. Martin, talking about basically what happens when the worst gallbladder comes into our operative field. So without further ado, we'll let Dr. Martin please close us out. We can't wait to hear this one.
All right. Thanks, Josh. So I don't have any conflicts. These are definitely my opinions because I'm going to have 0 data in this talk. I'm just going to be talking about some personal observations and tips. And like I said, I'm a nihilist for the gallbladder, right? There's no glory. Nobody expects anything other than a perfect cholecystectomy. You're not expected to have any complications or challenges. And we certainly know you're always millimeters from potential disaster. So, and on online videos or on Twitter, someone always posts a video or picture like this of, look, here's how you do a critical view of safety on every one of your patients and see how easy it is. And it's always the Robbins blue gallbladder, non-dilated, elective cholecystectomy that I think a lot of us rarely see, because what we're dealing with is more like this. And I have yet to see one of these people post how I get my critical view of safety in a gallbladder that looks like this. Or like this, that's dead already, and you're trying to get that out safely. Or something like this. This is a real shrieker. So you don't want to put your scope in and see your gallbladder covered with worms that are varices like that. So that would be advanced gallbladder surgery, I think. A word on trocar placement. I always start with a supraumbilical usually, and then subxiphoid. And then I look, and if I know this is going to be a terrible, tough gallbladder, potentially a subtotal chole, then I add not 2 additional trocars, 3 additional trocars. So now each person is operating with 2 hands, right? Because if you're struggling, one of your 2 people should not be a one-armed surgeon. So get 2 hands in there. This automatically makes the case easier and helps with exposure. And so now you've gone in and you're looking, and it's one of these gallbladders where you can't even see it when you put your trocar in. You're slowly peeling off this husk of omentum up. You get into something there that's an abscess. You're peeling duodenum off, and again, it looks like this. And your cystic triangle's a rock. So there's no way you're getting a standard critical view of safety in this case. And what are your options here? And, you know, and maybe you can hand it off to one of your partners, but usually you're going to have to deal with this. So one option is always convert to open. Again, I think a lot of times the exposure and dissection issues are exactly the same open versus laparoscopic. So I don't typically convert to open for these, but that's reasonable. But I think you always have to, like General Mattis said, be polite, be professional, but have a plan to kill everybody you meet. So have a plan to kill that gallbladder and get it out safely. And in my hands, that's usually a subtotal cholecystectomy. I think we've all seen the pictures of this. You want to open up the gallbladder, preferably somewhere away from the common duct or the right or left hepatic duct. And I'm just going to show some videos running through a typical case. So I like to mark the gallbladder, especially when I'm doing it with a resident, to show them exactly where I want them to go. So here I'm just scoring the gallbladder. And then the whole initial dissection should all be above that horizontal line I just scored. So that below where I'm scoring right now, that's not until you've opened the gallbladder and you've seen from the inside exactly where you are and what you're dealing with. Another reason for that additional trocar, put a endocatch bag in, especially if it's a gallbladder full of stones. You don't want to then spend an hour or two after you're done chasing down all those stones. So I'll put another trocar if I don't already have an extra one, put an endocatch in, and I'll just position it right under the gallbladder. It actually helps hold it up, and that catches all your stones in your bile when you open it. And then I always switch to an energy instrument, either ligature or harmonic. Here we're using a harmonic scalpel. And so then again, we're sectioning that upper half of the gallbladder, which we know is out of the danger zone, but below that horizontal line, we have no idea. And now only when we fish out the stones and start to look at the inside do we get a better idea of, okay, we can start going a little lower and taking it down, getting closer to the cystic duct area. And now we've actually, and as I often find in these, we've been able to find that distal cuff of gallbladder. That's actually the cystic artery we're able to find. And now the question is, do I try and close what I have left and do a reconstituting, or do I leave it open and do a fenestrating? And I think reconstituting has gotten a bad name, and I have no problems doing a reconstituting if I know I am way down and I am not leaving a big cuff of gallbladder, like in this case. So you can see we've got a tiny little cuff of gallbladder there. So I am not going to leave that open and have a bile leak. I'm just going to staple across that. And this is essentially, it was subtotal technique, but this is essentially a total cholecystectomy. If you have more gallbladder cuff than that, then I would leave it open. And then we're just excising the rest of those gallbladder fragments. You want to take out as much as you can, leave the posterior wall though, especially on that lower half of that dissection. And then you want to ablate any mucosa you've left. And I just turn the bovie up to 100, have them set the bovie on kill, and then I score that whole area, again, above that horizontal line we'd made. And so that's a pretty standard subtotal cholecystectomy. I think if anybody hasn't read the Be Safe program or knows about the R4U line, I find this very helpful. So if you find Rouvier's sulcus on the left and you draw a line straight across through segment 4, that's the 4, to the umbilical fissure, that's the U, also falciform ligament. If you stay above that line, you are generally above where the common bile duct or right hepatic duct is going to be. And if you're below that line, then that's the danger zone. And I found this to be incredibly helpful on these really tough cases where I'm trying to sort out exactly where the common duct is and isn't. And again, this is just showing somebody, you've left a giant cuff of gallbladder there. This picture, if you're leaving that much gallbladder and doing a reconstituting, I'd say retire. That if you're leaving that much gallbladder, one, you should never leave that much gallbladder, but if you have a decent cuff, that's when you should definitely do a fenestrating and leave it open. This patient's going to get recurrent cholecystitis 100%. So again, if I can mobilize it, I'll try and staple down as low as I can and do a reconstituting, but with little gallbladder left. And if you don't, you just, you can leave a drain in there. Some people suture the common duct orifice. I generally don't try that. You can leave a JP or a Malincott. If you get a bile leak, drain, drain, drain. If you get a bile leak, then just do a post-op ERCP and sphincterotomy. Now, I said that's my optimal approach, but I'll just say today, 2023, 2024, that's not my optimal approach. My optimal approach would be to whip out the robot and get in there and do this thing in comfort. And I think this is just the natural evolution, and our specialty has lagged far behind, and we need to get up to speed on our robotic skills. But I would much rather do one of these real challenging ones robotically now than I would laparoscopically. And so this is a typical delayed disaster gallbladder we got. This is one where Mira told you don't put a Pert Chole tube in these. Somebody put a Pert Chole tube in and then watched this patient septic for a week and then transferred them with a dead gallbladder. and a perc Chole tube. So in these cases, even if I'm going to do it laparoscopic, I start off, or robotic, start off laparoscopic, because you generally want to suck out all the bile or abscess that you can before you dock, because it's much easier to suction. So I get everything cleared. I see where my gallbladder is. You can see it's a dead gallbladder. Duodenum's plastered to it. And this is where now I think it's really nice to now just dock the robot. There's the perc Chole tube going into it. That was the one thing it was useful for, I'll say, is finding the gallbladder. It wasn't particularly helpful. Now we'll dock the robot. It's strong. The camera's great. It'll retract. You don't have to keep yelling at the resident for not retracting enough. And now we've got that big glob there. We have Firefly fluorescence imaging. So give ICG on every one of these. And then I just keep flipping back and forth between the Firefly view and the regular view to see where my common bile duct and where my cystic duct is. And you can see there, we're starting to get around the what we think is the cystic duct. And then when I stop making progress there, I'll just go up top to the dome, and I'll just keep doing dome down, bottom up, and I'll just keep going back and forth, making a little progress in each direction until usually then you find that you've pretty much met your top and your bottom, and you're done with your procedure. And again, here we are just flipping back and forth between the Firefly view. So now I know exactly where common bile duct is, and I know where I'm dissecting around what we think is cystic duct. There's no right hepatic duct or any other biliary structures in that area. And it's also much nicer having hemostatic instruments in both hands. So we have a monopolar scissors in the right hand, a bipolar in the left hand. So it's a lot more helpful for getting hemostasis. And now we've got it down. We did find the cystic duct. So we're actually doing a total cholecystectomy in this case, where I think if I was doing this laparoscopically, I would have done definitely a subtotal and probably converted to open much sooner than this in this case. All right. So in summary, the secret to happiness, I think, is to always expect the worst, and then you'll be pleasantly surprised when it works out. Don't be a one-handed surgeon. Get two hands on each side of the table. Know you're safe in your danger zones with both landmarks, the R4U line, IOC or fluorescence cholangiography, if you're lucky enough to be doing it robotically. Switch early to a bailout option versus persisting in a danger area. And then I think for the difficult ones, lap or subtotal robotic should be the standard of care for most of these cases rather than converting to open. And then don't forget about fluorescence imaging and real-time dissection, which I think really helps get these gallbladders out safely. And then drain, drain, drain. Expect a bile leak in these cases. All right, I will end there because I think we're about out of time. Thanks for the invitation and look forward to discussion.
That was great. Thank you, Dr. Martin. It's always convincing to have, awesome videos to share, you and Dr. Murphy both. We are running a little bit short on time, but there have been a couple of good questions submitted through the Q&A function. We said before to all of our panelists, we want to respect folks' time, but we're going to at least try to have 10 or 15 minutes of discussion because I think there's a lot of controversy or a lot of things that deserve chatting about, and we really want to take advantage of our expert panel here. There's a question from Zachary Terrell, which was a question for Dr. Keeley. And Dr. Terrell says, Dr. Keeley, the decreasing rate of cholecystectomy at index hospitalization is surprising considering all of the evidence you presented, and I suspect most surgeons are at least somewhat aware of the benefits of early cholecystectomy. Why the hesitancy? Is it the swift identification of mild versus moderate to severe gallstone pancreatitis? With your experience, do you think the grading systems you mentioned can be improved on? Thanks for the talk. Jess, what are your thoughts? How do we get better?
I think the well-readness of in-practice surgeons is difficult to assess. Those are a lot of papers and a lot of journals, but I doubt honestly that most folks who trained before they were published have gone back and read them. I think it's a lot to go through all of our kind of seminal publications and journals on a regular basis. And until, 20 years ago, we pushed on people's bellies until they didn't have pain before we operated. So if you learn that, you had good outcomes, that's what you still do. There's actually really good data saying we're awful at reading and implementing solid evidence into our practice. And we certainly haven't read that either because we're not doing any better. So I think there's probably a need to educate a little bit more, and put this out there in an easy to access forum, kind of along the lines of SAGE's Safe Cholecystectomy, really advocating for early cholecystectomy in these folks with mild pancreatitis. I think folks have been trying to make grading systems easier, and that's why there are so many. And we have yet to have that kind of perfect pie in the sky. Here are the 4 things you need. Look, we can't even do it for sepsis. We change that every 5 years now, 10 years, I guess. But we're
There is
trying.
no
People keep
purpose.
trying. I'm gonna leave that to someone else.
And then another question, I think for any of our panelists, is from Alex Merkel. Dr. Merkel asks, thanks for these great recommendations. For us out here in the sticks, do all these studies and recommendations apply to us in the community, or is it limited to well-resourced academic centers? The nearest level 1 center to us here in Northwest Montana is 8 hours away when the weather is passable. So we're cautious about delving into high-risk patients. I think any of our panelists can tackle that if they wish.
I think these are all very applicable to the majority of people's practices, in that if you do elective choles, which I gather most people in, community settings would do, you never know what you're going to get, And so what are you going to do if you get a disaster you can't manage electively? You're going to do what's safe. You'll, do what's in your skill set. And if you can't do what you think the patient needs, you'll stop and you'll close and you'll send them somewhere that they can get that. And all of the things that have been described today, early cholecystectomy for gallstone pancreatitis, direct to surgery with lap colon IOC, and, all the strategies described by Dr. Martin, and the lack of per chole tube placement, I think are all very available to community general surgeons. Yes.
Other thoughts from our panelists? How do we spread this good gospel? How do we get folks on board with not putting per chole tubes in folks or taking folks to the operating room?
Well, I think it's not just literature hasn't distilled its way down to, it's also, we have a biased view because most of us are at academic big level 1 centers. Most, gallbladder, urgent gallbladder consults are not at level 1 centers. They're covered by general surgeons, usually not acute care surgery service. And to add on a gallbladder for the next day usually means disrupting their clinic or their elective cases. And so it's just much easier to say, okay, just send them home and see me in clinic, because that's how they book their cases. So I think it's one thing that argues for an acute care surgery model in most places to get those urgent cases done. And I think that's a big part of what's driving it, as much as the, maybe not as familiar with the most up-to-date literature. But I mean, I think most of them know you should be doing it soon. It's just their practice isn't set up to facilitate that.
I also think there's a fear of an open chole, even if you don't have the lap skills, although with time now, people have more skills at doing a lap chole, fearing doing it, because you can still do a subtotal cholecystectomy open, you could still do an IOC open, you can do a lot of stuff open, and you don't have to be at a academic institution to do that. And so sometimes that is better for the patient than committing them to something like a cholecystostomy tube, because you saw the video Dr. Martin just showed, like, it did not make anything better. In fact, it was worse, and that's how we see, those are the patients that we see. And so sometimes it is okay to do that. So if your patient can tolerate being treated with antibiotics only for, let's say, cholecystitis, do that and then send them to somebody that might do their lap chole, so a higher level center. But if you can't, and if you, every once in a while you have to do a lap chole because it's not working out laparoscopic, it's really not the end of the world. Patients still do well. They get out of the hospital a couple of days after their gallbladder is out and they're done. And so that's kind of another thing. I think everybody sees it as a failure or worries that they're going to cause more injuries, but you can do everything, same thing open.
Yeah, I think that's an excellent point and something that bears worth reminding. Another question we had, and honestly, I think this is kind of the white elephant in the room, Dr. Murphy, when you were talking, Amanda Sinhu asked, and this was directed to you, Dr. Murphy, but I'd also love to hear Dr. Martin's opinion and everyone else on this. So for the young surgeons practicing in the community that sometimes have limited access to that ERCP, showing the benefit that you showed for the benefit of a transcystic common bile duct, how does one learn that technique? What's the best avenue that they would add that to their repertoire?
Yeah, that's a good question, because I said it's easy, but you do need to learn it. So you need to take a bit of a step back, because if the only time you're going to do that is once a year, on the most challenging patient with big stones, like, you need to decide if the patient population you serve would benefit and whether you'll be able to meet that kind of demand. And you kind of need a direct to surgery-ish approach, because you're going to need a few wins to get good at it, doing small stones. But probably the best way is to do a course at a conference. I believe AAST is actually probably going to offer it, or AAST is going to offer it. So that's probably the best way. And you can definitely make a homegrown kit. You can dust off the uretoscope. You can buy choledocoscopes. You can get all-in-one kits from industry, or you can clear it by fluoroscopy. But all of those, if you've never done it, are probably worthwhile to do a course and have someone proctor you through that. Just like any new skill, just like learning the robot, having a proctor and having a few early wins.
Got a question from Anonymous here for Dr. Martin. Can you tell us where the port was placed for the endo pouch to catch the gallstones on the top-down cholecystectomy? Is that for the assistant or the operating surgeon?
That one was just placed through the subxiphoid. So subxiphoid 12mm trocar. But if you still need all four hands plus the bag, just add another trocar. I would usually add it on the patient's left side. And on the getting started on lap common duct exploration, yeah. Sages offers courses, the companies offer courses, AAST is running a course. But and in terms of assembling your kit, I would say if you're going to start doing it, and I have zero financial relationships with any company, but the Spyglass system is such a nice, it's a single-use disposable choledocoscope. Those ureteroscopes break if you grab the end of it, and it flexes much more than the other scopes. So that's really revolutionized me doing it. I hated it when we didn't have that, but now I love doing them because it comes with everything in one kit that you need to do it. Wire, balloon. You can do your lithotripsy through it if you have the lithotripsy device. So I would recommend the Spyglass system if anybody's going to get started and can convince their administrators to spend a little money.
It does the transcystic, particularly in facilities with bundled care models, in that you get paid a set fee for this patient population. There is an argument for that capital purchase, whichever one you pursue, because if you can save money on ERCP and MRCPs, the hospital pockets that cash for bundled care. And that equipment is not that expensive, and it doubles the RVUs for one of these cases.
And you might already have it. For example, at our place, interventional radiology uses it a lot. They used it way before we did. So like in R1 hospital, we found out our IR guys already had it. So we just bring it up from the IR suite when we need it.
Now, I think this conversation would be remiss if we didn't ask another controversial question related to bad gallbladders. We heard timing for gallstone pancreatitis, but what about the timing during the day? So I know there's institutional differences with the panelists on board on when these gallbladders actually go. So with respect to the bad gallbladder, with respect to the bailout, with respect to the operative first approach, does timing during the day come into a factor with each of your approaches when you're handling these bad gallbladders?
This is one of the reasons that people don't get their gallbladders out for gallstone pancreatitis is emergency general surgery patients are often not the priority for hospitals. And so they take a back seat to elective cases, and operative resources aren't dedicated to them. And there's pretty good evidence that hospitals with dedicated daytime services have a higher index cholecystectomy rate, which I think is shocking to no one. But, I'm going to give my personal opinion is no gallbladders after 10 p.m.
That feels like a very upper Midwest answer. I was going to say no gallbladders after 7 p.m. here in South Central Los Angeles.
Same in Baltimore.
Yeah. But Pat, I think you have a really important point there. Dr. Keeley and I work in a system where we have the acute care surgery service has its own room 24/7, 365. That's not our red room. That's not an elective room. It's the urgent room. And when Jess and I were an intern and a 10 years ago, the average length of stay for gallbladders at Harbor was 5 days. And it is now 2 days, or maybe even less than 2 days at this point. But it's a good question, Josh, because I think the reality is I think the other thing, I thought when you said elephant in the room, we are going to talk about the big $1 million elephant with 4 arms, the robot, because the reality is that some of the places where y'all work have that facility to allow acute care surgeons daytime access to that machine, and some folks don't. And I think that also sort of raises an interesting idea about how do we provide timely, appropriate, perhaps technologically advanced care to our acute care surgery patients. And I don't know, I know that Dr. Murphy and Dr. Martin, you both use the robot in your practice. I'm curious, how did you get daytime access, or are you just like a midnight roboticist?
So we don't have, at one hospital, we don't have daytime access. At the other hospital, we do. So it just depends on your setup. But a lot of places have pushed for and gotten after hours access for the robot. And a lot of places, it was the surgeons finally saying, listen, I'm just not doing this case unless you give me the robot and support it. But it's something you gotta start with your local leadership. So your division chief, department chair just needs to be behind it. And that's just slowly chipping away.
Yeah, most of these are, I think, the access to resources, operative or equipment, are a leadership thing. And for, you don't have to reinvent the wheel. These have been somewhat established, even at non-academic centers, like 24-hour access to the robot. Lots of hospitals in my community had that before we did, because they do all their cases robotically. That's just how they do it. And we are very far behind because, just like there is no such thing as an emergency laparoscopy, there's no such thing as an emergency robot these days, which I fundamentally disagree with. And, same with the access to daytime operative resources. If you can demonstrate a length of stay reduction and opening up more beds for more patients to be cared for, that, rings true to the people who hold the purse strings because they can make more money.
That's excellent. Well, what are the discussions on midnight roboticists? I think you guys are all the Cape Crusaders of cholecystectomies, and we thank you so much for being on this call.